The conference is now being recorded.
Hello, everybody. Welcome to the ADAA webinar. The topic for today's webinar is depression, what you need to know about medications. I'm Dr. SUMA Chand. I'm an associate professor in the Department of Neurology and Psychiatry at the St. Louis University School of Medicine. I'm a clinical psychologist specializing in cognitive behavior therapy. I'm a member of the ADAA Public Education Committee, which produces this series of monthly webinars. Let me give you some guidelines about the webinar. You can ask your questions at any time. Rather, you can type them in at any time. On the right side of your screen, you should see a Q&A panel. There's a little field at the bottom of that panel, and when you click in it, you can type in a question. Then either hit your Enter key or click the icon. Other participants cannot see your questions. Your questions will be answered at the end of the presentation, and we'll try to get to as many as possible. We may not have time to get to your individual questions sometimes, so we do apologize if that is the case. Now, you should be listening to this webinar through your computer speakers. You don't need a telephone connection. If you've dialed in, please hang up and turn up your computer speaker. We are recording this webinar to make it available on the ADAA website at a later date. Today we'll be hearing from Dr. Beth Salcedo. Dr. Salcedo is the Medical Director of the Ross Center for Anxiety and Related Disorders. She's Assistant Clinical Professor of Psychiatry and Behavioral Sciences at the George Washington University College of Medicine and Health Sciences. Dr. Salcedo is a psychiatrist with expertise in diagnostic assessment and psychopharmacologic management of anxiety, depression, and mood disorders in adults. She has been the medical director of the Ross Center since 2002 and has been with the center since 1997. She has been named in Washingtonian Magazine's Top Doctors in 2010 and again in 2012. Dr. Salcedo has been an active member of ADAA since 2004, chairing the membership committee and serving as treasurer on the board of directors. Before we begin the presentation, I'd like to tell you about ADAA, or the Anxiety and Depression Association of America. It was started in 1979, and today it is a leading nonprofit organization dedicated to increasing awareness and education about depression, anxiety disorders, obsessive-compulsive disorder, post-traumatic stress disorder, and related illnesses. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and cure of these disorders through education, practice, and research. ADAA fights to end stigma by promoting the message that these disorders are real, they are serious, and treatable. Please visit the ADAA website, that's www.adaa.org, which includes Find a Therapist, a searchable database of treatment providers, as well as free educational information and resources, self-tests, self-help groups, clinical trials, and a lot more. You can support ADAA's efforts, such as this webinar series, by making a charitable contribution on the ADAA website. Remember, you can type a question at any time. Now let me turn it over to Dr. Salcedo. So Dr. Salcedo, you're on.
Okay, great. Thank you, Suma. So I'm just going to go ahead and start here. I have a couple of things to mention about myself. One is that I treat primarily adults. It's rare that I see someone under 18. So while the issue of medication and treatment of depression in kids is pertinent, it's not something that I feel that I have expertise on. So I'll say a couple of things about it, but that's really not my area. And then the other thing that I'd like to say is that I have mentioned in this presentation several medications by name, both generic and trade names. And I want to disclose that I don't have any financial relationship with any of the pharmaceutical manufacturers. So first I'll talk a little bit about depression, just to give you an idea of what I'm speaking about specifically. There's lots of different types of depression, and depression certainly is a term that's used widely in our vernacular. What I'm speaking about is treatment of specific depressive disorders. I think that the term depression can be used pretty casually, and we're really talking here about depression that is a diagnosable illness versus, a reaction to a situational stressor. There are several different types of depression. The first two, major depressive disorder and persistent depressive disorder, will be what I'm speaking about primarily, and I'll tell you a little bit about those. Depression that is associated with bipolar disorder is a very different treatment mode, and so that's not really what we'll be addressing today. So for people with bipolar disorder that enter into a depressive phase, the treatment is very, very different from what we're going to be speaking about today. And then again, depression in children and adolescents, I will leave that topic for someone who has expertise in the younger children and the younger and older adolescents. And then the other thing that I'll say again is that not every thing that looks like depression is really a truly diagnosable clinical depression. For example, grief and loss can look very much like a clinical depression, and it's not necessarily warranted to treat that, certainly not with medication. So that also probably belongs to a different talk, since we only have an hour today. So major depressive disorder is probably the most common depressive disorder that I mentioned. It's usually an episodic illness. It is something that can come once in a lifetime or multiple times in a lifetime. This is an episode that will last at least 2 weeks, and it has quite a few symptoms that are very, very serious for people. They usually impair functioning in at least a couple of areas of their life, whether it be work, school, or their personal lives. And it can be very, very distressing, and that's what usually causes them to present for treatment, is the level of distress and impaired functioning. The symptoms can be many. I've listed a few here. Often people feel sad. Sometimes they feel flat or empty. This feeling lasts most of every day and most days. They will lose interest in things that they usually find interesting. Sometimes people say they stop reading for pleasure, and that's their first symptom. They start saying no to social invitations. They withdraw. They can't enjoy things anymore. They will lose sleep, or they'll sleep all the time. And similarly for appetite, they'll be eating all the time for comfort, or they won't have any appetite to eat at all, and they might lose weight. Energy is often a big problem for people with depression, and they say that everything takes a whole lot more effort to do, even just the basics like showering and driving to work. They have trouble with focus, whether it be work or school. They often feel worthless and feel like they're no good to anybody. They can get very hopeless about their situation, and they often feel very guilty about the fact that they're not participating. Persistent depressive disorder used to be called dysthymia. Recently, with the changes in the DSM, they decided that this persistent depression that they called dysthymia should be paired with a chronic major depressive episode. But what we know of as persistent depressive disorder is really more of a milder presentation of depression that lasts a lot longer. By definition, it should last at least a couple of years. The symptoms are the same, but they might be less intense, and there may be fewer of them. And in some of the literature, it seems that this persistent depressive disorder is a bit less responsive to treatment. But the treatment is going to be the same, whether it be medication or psychotherapy, and we'll talk about that. So again, there are several different types of depression. Bipolar depression, as I said, is not something we'll go into here. A lot of people refer to postpartum depression, which, as its name indicates, is depression that starts right after giving birth. And this postpartum depression is, again, treated the same way. It's really considered a major depressive episode, but with the specifier that it's a postpartum onset. Similarly, seasonal affective disorder, which is when your symptoms begin, usually when the light, the length of the day shortens, late October, early November, into the fall and winter, and it might last through mid-March, say. So this is considered seasonal affective disorder, but again, the real nomenclature for this is major depressive disorder with seasonal variation. And then there are depressive episodes that can occur in the context of something else. This is, again, the treatment can be similar, but other factors need to be addressed. So certainly people who have drug or alcohol problems can get depressed in the context of their drug or alcohol use or withdrawal, and certain medical conditions like hypothyroidism, other endocrine disorders, pancreatic cancer, heart disease. These things can present sometimes initially as a depressive episode. So everybody that experiences the depression should really get a full physical in order to rule out these other things. The treatment of these could be both treatment of the underlying cause, but sometimes these situations will need depression treatment that we're about to discuss. So for example, in patients who have strokes, oftentimes they'll experience a depression in the context of that, and the treatment of the stroke won't necessarily be enough to pull them out of the depressive episode. So they'll need to get some mental health specific treatment. Depression in our country and all over the world is a huge problem. Just to give you an idea of how big of a problem it is, at any one time, studies indicate that up to 10% of the population can be experiencing depression. That's 19 million Americans. Of these people, women are at much higher risk, about 70% higher risk. Anywhere from 10 to 25% of women will have a depressive episode in their lifetime, and anywhere from 5 to 12% of men. Adolescents, again, highly affected. The CDC in 2012 determined that 1.5 million adolescents had a major depressive episode that year. So it's a very serious problem. The functional impairment in people with all kinds of depression is quite high. Up to 80% of people will have functional impairment, even in the milder illnesses. And 30% of people with depression will have very serious difficulties both at work and at home. The highest rate of depressive episodes is in the 40 to 59-year-old age range. But again, it really affects all ages. There are tremendous human costs to being depressed. People who don't get their depression treated have a quality of life that is not the same as if they were to. Their relationships aren't as good. They're not as likely to marry or stay in long-term intimate relationships. They're not as likely to achieve what they otherwise could have in terms of their educational goals. They're much more likely to have drug and alcohol problems, and they have lots and lots of relational issues. Suicide is a huge problem with depression. People who experience depression have a 30 times greater risk of committing suicide. And suicide for Americans overall is the 10th leading cause of death in the country, 41,000 suicides in the year 2013 alone. And for kids, believe it or not, it's the third leading cause of death for kids and really young adults up to age 24. So it's a very serious problem. The economic cost of depression, the disability in this country due to depression is quite high. 200 million days of work are lost every year in this country due to depression. The cost to the employer is anywhere from $17 to $44 billion estimated annually. And for the sufferer themselves, the person suffering with the illness, their income is likely to be reduced over their lifetime by as much as 35%. So when someone initially presents with a complaint of depression to me or to many mental health clinicians, the first thing that they want to do is to confirm the diagnosis. Part of this is to make sure there's not an underlying condition that can be contributing, like a drug abuse problem. The other part is to make sure that the diagnosis is really there and warrants treatment, and to make sure that this isn't part of a bipolar illness that would then take the treatment down a completely different path. I always make sure people have had a recent physical since having been depressed, and I want to make sure to address lots of lifestyle issues with them, both initially but over the course of treatment. This being whether they have good relationships at home, good support at home, what's going on at work that could be contributing, how is the stress, and how are they managing? Do they take care of themselves with meditation, with yoga, with exercise? How do they eat, and do they have a good nutritional status? And hugely important, are they sleeping? Do they get enough sleep? Do they know about good sleep hygiene? And if they're not getting enough sleep, do they know how to address their needs for sleep? There are lots of treatment options for depression. Again, we just discussed some of the lifestyle issues that should be addressed both initially and throughout the course of treatment. The treatment options I'm going to talk about today are the ones that have the most evidence behind them, meaning they've been studied well and they've been determined to work. There are plenty of other things out there that don't have a huge evidence base that do work for some, but that will not be part of what I'll address today. First-line treatment for most people with a diagnosable depression is going to either be psychotherapy or medication for most people. If the depression is mild or even moderate, if the person is able to function at a reasonable level in all the different aspects of their life, then psychotherapy would be a great first option. I really encourage psychotherapy first because it provides people with a lot of things that medication alone cannot. But not everybody is willing to go that route. We'll talk about that a little bit more in just a second. If the depression is severe, then a combination of medication along with therapy should really be offered first line. And there's been some interesting information about teenagers recently that a combination of a type of psychotherapy called cognitive behavioral therapy along with medication can exceed the response rate of either alone, and that those kids respond better, faster, and possibly longer. So again, psychotherapy is really what I recommend first line, prior to medication. Most of the studies indicate that good psychotherapy will provide the same treatment response as most medications out there. And people who have experienced good psychotherapy will have tools, skills that they can take with them beyond the treatment course. And the benefit really lasts a little bit longer once the psychotherapy has stopped versus when you stop medication. Good psychotherapy can really be empowering for people, and it doesn't have the potential for side effects like medication can. There are lots of different types of psychotherapy out there. The ones with the most evidence base behind them are the ones I've listed here: cognitive behavioral therapy, interpersonal psychotherapy, DBT or dialectical behavioral therapy, acceptance and commitment therapy. There are others that are being studied and looked at and certainly practiced, but these are probably the four most commonly, widely recommended at this point. And then the goals of therapy are many. I have a few listed here just to give you an idea. People need to identify their negative beliefs and their behaviors that bring the depression on and sort of encourage the maintenance of the depression. They need to replace these distorted cognitions with healthy, positive ways of thinking and behaving. They need to look at their relationships and the experiences they've had in their lives and learn how to, change those to a more positive way of interacting. They do problem-solving skills, coping skills. They learn to set goals that are realistic, and they develop an ability to accept the distress, tolerate the distress, and manage it using healthier behaviors. So now we'll talk about medications, since that's the role that I play in my center. Again, usually what I'll explain to people is the utility of therapy is really fantastic, and I'll encourage them to explore that first, again, unless the symptoms are very, very serious. And if they have done that and they don't feel like they're getting the response they'd like, then we consider medication. Sometimes people will go with medication first line, and that's often a personal choice. When do we choose medication first line? As I said, in a severe depression, people often are not able, they don't have the energy and the wherewithal to really participate in therapy. So sometimes those patients might initially start with medication, and as they start to improve, then therapy can be added in. Some people will tell me that they don't have time for psychotherapy. They might be young associates in crazy, busy law firms in downtown D.C., and they work 18-hour days, and those people are probably not going to put the time and effort into therapy that they need to. So in those cases, while I might prefer therapy for those people, they still deserve to be treated. So we'll do a medication trial and see what we get with them. Some people just, in general, prefer medication. They don't believe in therapy. They don't want to do it for whatever reason. Sometimes therapy is not available. In the lesser populated parts of this country, there aren't always enough therapists with open time to see everybody that needs it. And then there are definitely people who don't respond to psychotherapy. The response rates are great, but they don't take care of everybody. So if people aren't responding, sometimes choosing medication next is a great next option, or adding in medication. So how do you choose which medication? Basically, all the medications that we have out there are equal in terms of efficacy over the population at large. So what that means is that they might work well for the same percentage of people in, cohorts of thousands of patients and studies. Different people will have different responses to different medications. So it's really important that people understand that just because one medication works for one, it doesn't work for everyone, and that they don't get discouraged. It's really important to think about trying, 2 or 3 potentially medications if the first one doesn't work. They all work very similarly. They work on the neurotransmitters, or the chemicals in the brain that allow the nerve cells of the brain to communicate with each other. Serotonin, norepinephrine, and dopamine are the primary ones that they work on. And they also, some of the newer medications especially, also work at the receptor site that these chemicals bind to. And there's a chain of reactions, a cascade that happens after that initial increase in neurotransmitter that is still really being elucidated. We don't fully understand how these medications work. And the medications that you're going to choose are really going to depend on what side effects you want to avoid, or what side effects you want to take advantage of. For example, if someone's not sleeping well, you might choose a slightly sedating medication so that they can get some benefit for sleep. If they're on multiple other medications, you've got to be careful about which medications might interact with the other medicines they're on. If they've had a prior treatment experience that was positive, if someone comes in and tells you they've responded well to one medication, it may make sense to go back to that. Usually if they responded well and tolerated a medication 5 years ago, they're going to respond well and tolerate it now. And then some people who have never tried medications might say, 3 of my friends are on X, Y, or Z drug, and they've done well with it, and they tolerate it. I'd really like to try that one. And if there's no contraindication, it may make sense to go with that. The other piece is that certain medications have a withdrawal potential. And when I see somebody, especially someone who is taking medication for the first time, my goal is to get them treated and eventually, hopefully, maybe get them off of medication, usually using cognitive behavioral therapy or another effective psychotherapy in order to manage that. And so part of me wants to make sure I get them on something that's going to be relatively easy to get off of. And we'll talk a little bit about the medicines that are a little bit harder to take than the others. So I don't want to go too much into detail on specific medications. This is a list of what are called SSRIs. They are specific serotonin reuptake inhibitors, meaning they increase the amount of serotonin that's available for the nerve cells to use to communicate with each other. Prozac was the first one that came out way back when, I think probably 25 years ago now, and then the others have followed. Again, the effectiveness of all of these things is equal. Luvox, I would say, it first came out actually indicated to treat obsessive-compulsive disorder. And all of these medications do also treat many of the anxiety disorders and have FDA approval to do so. The makers of Luvox initially really wanted to try to target OCD, so they brought it out as indicated for OCD. And I don't believe it's ever gotten the indication for depression, but it is probably just as effective, although it's not really used widely for depression. So these are all of the SSRIs. And then we have the SNRIs that I've listed here as well. Effexor was the first one. Prestique is the active metabolite of Effexor. It's called desvenlafaxine versus venlafaxine, and it probably is a little bit better tolerated than Effexor, but it's a little harder to get off of because we don't have multiple dosing options to do a taper of. And these medicines as a whole, in comparison to the SSRIs, are more difficult in terms of the likelihood of withdrawal. So for me, this class of medications may be second line. They work through serotonin and norepinephrine as far as kind of increasing the amount of those neurotransmitters that are around. And we're not sure really why they're harder in terms of withdrawal. Cymbalta is also used quite frequently for certain pain syndromes. It can be used to treat diabetic neuropathy pain, for example. So that may be a reason to choose it first line over an SSRI if that's, you know, a potential second treatment option for a patient. There are lots of other medications. These are just a few. I bring them up because I think they're well used for certain things. Wellbutrin is a great medication. Everything else that I've mentioned so far, the SSRIs, the SNRIs, and most of the other antidepressants actually, are widely used for both depression and anxiety. Wellbutrin, on the other hand, is really primarily used for depression. It's a little activating. So in someone who's also very, very anxious, it could potentially make them a little bit more anxious. Now, having said that, once someone responds to Wellbutrin, once their depression responds, it turns out some of the anxiety scores that that are on rating scales used in research studies, some of those anxiety scores can actually go down as well. So if anxiety is a very small part of the picture, Wellbutrin might be an appropriate choice. And I really like it as a whole because it has less weight gain and sexual side effects. In fact, it doesn't usually have those. And everything else that I've mentioned so far, the SSRIs, the SNRIs, can have both weight gain and sexual side effects for people. So Wellbutrin is often a good first choice. This is, you know, a generic medication. Everything that I've mentioned so far, aside from Prestique, is available as a generic. So that's generally a more cost-effective option for people as well. And all of the first four medications listed here, Wellbutrin, mirtazapine or Remeron, trazodone or Deserel, and nifazodone or Cerazone, they're all available as a generic. Mirtazapine also has less sexual side effects. It can be quite sedating, which can be both a good thing or potentially a bad thing. Trazodone is an antidepressant that's used often in combination with other antidepressants to help with sleep. And in low doses, it can be a nice sleep aid. In higher doses, it can be antidepressant, potentially overly sedating. So it's not as widely used. And then nifazodone, again, also a very effective drug, less likelihood of weight gain or sexual side effects, but there was some indication that it had a greater chance than all of these other medications to cause some liver injury. So liver function tests have to be monitored regularly on this. And then what we are seeing lately is that some of the atypical antipsychotics or the newer antipsychotics that are out for treating schizophrenia are also being looked at in research studies to treat both depression that doesn't respond to other medications or depression in the context of bipolar disorder. So these are a few of them. They're names that you might see in the literature, in the media. They're sort of widely advertised in popular publications like People magazine, et cetera. These are not at all first-line drugs. They have a wide side effect profile that's really important, but they do have a very important role in the treatment of depression. But it would be a third or fourth line option or an add-in option, and we'll talk about adding drugs together in just a minute. Older drugs that, again, equally effective but generally less widely used because of the side effect profile, tricyclic antidepressants were really the most widely used drugs before the advent of Prozac. And there's a few of them listed here. They have a lot of potential for weight gain, sedation, dry mouth, constipation, and they're potentially dangerous and overdose. So they're not as widely used today, but they are still considered very effective. And then the MAO inhibitors, you'll see these drugs mentioned on the back of almost every over-the-counter medication. If you're taking an MAO inhibitor, please, talk to your doctor before taking this over-the-counter medicine. These are, again, very effective medications, but very difficult to take because they have some very serious potential interactions with certain foods. They have a very significant potential for raising blood pressure to dangerous levels if you don't follow a very strict diet or if you take, another drug that could interact with them. So they're potentially very dangerous, and they're really only for people who can follow very strictly these dietary restrictions. There are a few new medicines. I won't go into them in any great detail. What I have seen so far, both in the literature and in my own practice, is that they're probably equally effective to the older things out there. Sometimes there are reasons to try them, especially in patients who have tried multiple things and not been able to respond. But they are newer and therefore more expensive. These are all drugs that are not generic yet. It's possible because they have a little bit different mechanism of action that we're going to see something different from them, but I think it's too early to tell. Vibrant is one. It also works through serotonin like the SSRIs and the SNRIs in part, but it also has some activity at one of the serotonin receptors that is felt to potentially give it a bit of difference and possibly something that we don't see in the other drugs. I haven't seen that yet in my practice, but again, it's too early to tell. One negative with Vibrant is it has to be taken with food, or you don't absorb it all, and it's expensive. Brintellix, similarly, it's considered multimodal. It works through serotonin reuptake, and it works through multiple serotonin receptors. So we're hopeful that maybe that will give us a little bit greater rate of benefit. But again, it's too early to tell, and what we've seen so far is not real different from what we have already. It's possible that there's going to be less weight gain or less sexual side effects from any of these new medications, but we always think that that's possible, and it doesn't always turn out that way. And then one other one that's new is called SUMA. It's a MRI. It works through both serotonin and norepinephrine, and it's related to an older drug called Savella, which never got approved in this country for depression, but has been approved in other countries. Again, I'm not seeing anything in terms of more efficacy with this drug or any of the others, and it's more expensive. But for people who've tried multiple things and failed, it makes sense to go with some of the newer stuff. When people get started on medicine, again, usually those first couple of slides with the SSRIs and the SNRIs are going to be my first choice. For someone who's got a real straightforward depression without a lot of anxiety, Wellbutrin will probably be my first choice. None of these medicines needs any blood work to get started. There's no blood work monitoring that's needed for these. Again, I like for someone to have a full physical exam to look and see if there's any potential medical complications like hypothyroidism that could be either the cause or maintaining the depression. And then a lot of people are now asking about pharmacogenetic testing. That also is a topic that probably deserves its own hour at least. This is when we look at the genes of people and see if we can figure out whether they are slow or rapid metabolizers of certain drugs, or whether potentially they may respond to one or another drug first. This is not quite ready for prime time, in my opinion. I do use this occasionally in people who either have a lot of side effects, and so possibly they are ultra-slow metabolizers of medications, or in people who can tolerate the highest dose of a medication that I prescribe but don't respond. Those people could be ultra-rapid metabolizers, and it's possible that they're just not eliciting a blood level that will allow them to get some benefit. But again, this is not something I would do for people who are new to medications or just trying the first couple medications. Most people really, they've been suffering for a while by the time they decide to get on medication. It's important that they realize that this is not a quick fix. It takes a couple of weeks just to reach a therapeutic dose, and then it takes anywhere from 4 to 6 weeks total to even see the potential benefit of that therapeutic dose. So one example might be sertraline, which is the generic name for Zoloft. The dose range of that for depression is anywhere from 50 to 200 milligrams. I'll get someone on 50 milligrams by day 5 or 6. It'll be, day 14 to day 20 that I expect to see anything at all from that dose. And if they're not responding, we will increase down to 100. And then we might give that 10 days or 14 days, and then increase to 150 if we're not seeing anything. So it can take a while to really get your benefit. Some people want to be really aggressive with medication, and they'll say, look, if it's possible I'm going to need 200, let's jump to that as quickly as possible. And so we might increase the dose every 4 days to get them to the highest dose that they can tolerate and therefore get their benefit quicker. But most people would prefer to be a little bit more conservative. So they need to give you several weeks to see their benefit. Having said that, when people start to see even a little bit of effect, it can give them so much hope that it becomes much easier to wait the time out that they need to get their benefit. And then I'll mention quickly the black box warning on all of these medications. Many years ago, there was some data that came out that indicated that there's possibly early on in treatment an increased risk of suicidal ideation in children and adolescents and even young adults up to age 24. We don't really know why this is. It's possible. Some people theorize that they get a little bit energized from the medication before their mood starts to even respond. And so while they might have had suicidal ideation, they didn't verbalize it. Once they start feeling, a little bit of energy from the medicine, they might verbalize it and potentially act on it. But it's not really clear. But for this reason, the monitoring, especially in children and young adults, but for everyone, really needs to be quite close, and contact needs to be frequent. So how do you know a medicine's working? What are you looking for? Usually, like I said, the benefit is slow and it's subtle. Most people will say in the first couple of weeks the edge is off. They notice a few little things like, my husband said I was laughing more, or I picked up, a book for the first time in ages. I'm still depressed, but at least I'm actually reading and focusing and able to enjoy my book. So they'll have very specific things that they'll see, and slowly over the weeks, they'll have more and more and more of their symptoms start to resolve. Even early on, if they can get a little bit of improvement in energy, for example, that might encourage them to go for a walk with a friend. That exercise and that social interaction will encourage the mood lifting. So the medicine is really just one tool that allows them to make use of other tools in their life that can be a real good treatment for them, or part of a big treatment plan for the depression. Side effects are definitely what people talk about most with these medications. In general, if the medicines are managed well, the side effects can be easily managed. That doesn't mean they'll easily go away, but nobody has to live with side effects for a long, long time. Usually it's a short-term thing. People might be nauseated for the first few days on a medicine. They might be a little bit nervous for the first few days on a medicine. It usually goes away by 5 to 7 days or so. And if it's tolerable and they can live with it for 5 or 7 days, they will, and then they'll start to see their benefits. They can be sleepy, or they can have trouble falling asleep. They can have dry mouth. And again, these are things they need to bring up quickly with their doctor and figure out whether there's something else they can do to take care of these things, or whether they need to either take the dose more slowly or possibly try a different drug. The side effects that are most widely discussed in blogs and on drug websites that patients go to are sexual side effects and weight gain. And these are both side effects that people don't necessarily notice early on. Often people's libido is suppressed when they're depressed, so they may not notice that it's the one thing that's not coming back as they improve. They also often will either have gained weight or lost weight initially, and their diet's off, and so they won't notice that weight gain actually might have to do with medication until several weeks into the treatment. These are things, again, that are completely reversible. Sometimes what I've found is the sexual side effects can be mild, and if people can wait it out a few weeks, sometimes it goes away, and I can't explain why that is. Similarly, for weight gain, some people will have a little bit of a slow creep in their weight. They don't usually gain 5 pounds overnight. They might gain a pound or 2 a month, or maybe up to a pound a week. I usually warn people when I put them on medicine to watch their weight. And then oftentimes they can lose the weight even on the medicine. If they diet and don't lose the weight, then it probably means either a dose reduction is needed or an alternate medication. And then sometimes, I had mentioned Wellbutrin earlier, sometimes adding Wellbutrin in as a second drug sometimes can mitigate these side effects. Not everyone wants to do that, but oftentimes people will be agreeable to that if the initial drug has been very helpful for mood and anxiety. Both of these side effects, again, are completely reversible. They're usually dose-related, so they might show up at the higher doses when they didn't show up at the lower doses. And again, manageable through a variety of ways. Once you've had an experience on a medication and had a side effect, you won't necessarily have that same side effect on another medication, even in the same class. So this shouldn't discourage trying something different. Plenty of people, unfortunately, don't respond to treatment. Up to 30% of people in studies are considered treatment-resistant, meaning they have tried and failed 2 different medication trials. So sometimes adding a second agent for those people makes sense. Sometimes, again, adding a second agent to mitigate side effects of the initial agent, like I said, with Wellbutrin, makes sense. For augmentation, when you're trying to get more benefit, lithium and thyroid hormone are probably the best described in the literature. Wellbutrin is probably the one that is most frequently used. Both lithium and thyroid hormone can have a multitude of other side effects and need a lot of blood monitoring, so they're just not as frequently used, even though they probably should be. Buspar is an anti-anxiety agent that often is felt to be somewhat effective for sort of boosting the effect of an initial agent. And then the atypical antipsychotics, again, like I mentioned earlier, can be used to boost the effect of the initial drug in treatment-resistant depression. And then length of treatment is extremely important. People need to stay on the medicine until they've gotten a good chunk of time under their belt. Oftentimes they feel better and they feel like, I don't really feel like I need this medicine anymore, and it's certainly understandable. But what we know from the studies is if they are in remission, meaning their symptoms are gone, for at least 6 to 9 months, then they can get off the medicine and have a much less risk of relapse into that same episode. So I really encourage people to think about a minimum of 6 months. I'll push them closer to at least a year. And then I want to explain to them that the risk of recurrence is there, and it's quite high. One major depressive episode will lead you to having a recurrence at least 50% of the time. Now, that could be next year or it could be 10 years from now. So it certainly makes sense to think about getting off the medicine. But it needs to be with the knowledge that a recurrence is possible. And I spend a lot of time talking to people about how their depression starts and how it presents and what are the first symptoms, what's the second symptom, how does it change over time to the point where they feel they can't take it anymore. And I want them to really, remind themselves of what it's like so they can catch it early on if it does come back. And then we've got a recent study that I think is interesting that shows that treating older adults, 55 plus, with interpersonal therapy and with medication at the same time, and treating them to remission and keeping them in remission for 2 years shows that their likelihood of a recurrent major depressive episode is much, much lower if they get that much treatment under their belts. So it's really a mistake to try to get off medicine quickly at this point. And we don't have that much data to guide us, but we're starting to see a little bit more. So again, stopping medication is something I like to bring up early on. Most people do want to eventually stop medication, so I want to make sure that they know that we have that option. We want to give ourselves enough time in treatment, in remission, to make sure that stopping is happening at a good time. I usually taper things when there's stability, not when they're changing jobs, not when they're getting married or getting divorced. not when big changes are happening in their lives, and when they feel really ready. Now, the one caveat with this is if I have a woman of childbearing age who wants to get pregnant, these sort of guidelines go out the window, and that's a whole, again, another topic for another hour. Generally, in most people, I'll taper over a 2 to 3 month period. I feel like that just gives them a better shot at seeing what they're like on the lower doses, getting comfortable with the idea of being on the lower dose, and potentially seeing symptoms coming back if they're going to, and getting potentially back on medicine or adding in psychotherapy as symptoms come back, but before they've become much more depressed again. And then you want to avoid withdrawal. Withdrawal can be very uncomfortable. It is a possibility with almost every medication out there. I've not ever seen it with Wellbutrin, but I've seen it with everything else. Some medicines are notorious for it and some less so, but it's a possibility. So I want to avoid that. Our bodies get used to having certain medications in them. It's not that we're addicted to the medicine. It's that our bodies are just used to it, and our bodies are organisms that conserve energy. So whatever the medicines are doing, our body will sort of redirect their efforts elsewhere. A good example is that if you are on a blood pressure medicine, then that medicine's controlling your blood pressure, and your body doesn't have to do as much work to control it. If you abruptly stop that medicine, you could have what's considered a rebound hypertension, or your blood pressure could shoot back up beyond where it was previously. And so tapering high blood pressure medicines is also common practice. The withdrawal can be uncomfortable. It's not dangerous. It's usually dizziness. It's sort of flu-like aches and pains. It can be these weird feelings like energy shooting through your limbs or even your brain. People call them brain zaps. They don't hurt. They're just really distracting and annoying and disconcerting. So I like to avoid that if possible for obvious reasons. And then just kind of to wrap up, my take-home points are that medication is one of many, many, many tools to treat depression. It's certainly not the be-all, end-all. It should be really well thought out, and it should be well thought out in the context of what else can I be doing to make sure that I'm taking good care of myself and getting the good psychotherapy that I need. There are lots and lots of good medicines out there. Most of them are tolerable and easy to use if you know how to use them, starting with low doses, escalating the dose slowly and carefully, having a lot of communication with your patient is really the best practice and should be standard of care. And always keeping in mind what else can we be doing. If we choose medication first, when should we add in psychotherapy? Should we add in psychotherapy? Do we need to add a second medication? Is the person responding enough to where they should be able to get out there and exercise and take care of their sleep habits, et cetera? So I think medication is a great choice, but it is one of many, and that is the big message. So I don't see any questions so far. I don't know if anybody has any. I'm certainly happy to answer questions now. We've got a few minutes left. Suma, am I correct in my Q&A is blank?
There are a couple of questions here.
Okay.
So I will just read out what one of our attendees has said. He has a question about his personal experience with medication. And he's saying that it's been only the last 6 weeks that I've been doing better, but this ordeal has been going on for 7 months. I have tried numerous medications, but it seems that a combination of Britalix and Abilify is helping. Now that I've been doing better, he asks, will each day get better?
Well, certainly, like I said, I think even a small amount of improvement can be enough to allow people to make other changes. So exercise is always my go-to. If someone's got enough energy to start exercising, that can make a dramatic difference. 10 minutes of exercise a day has been shown to have a benefit for sleep, for improving the quality of sleep, for mood, for anxiety, and for other medical issues. So if you are starting to see some benefit, you should continue. And while the general rule of thumb is it takes anywhere from 4 to 8 weeks to see the benefit of a medication, oftentimes, even without any other changes, people will see continued benefit for a few months out. So what I usually say is you're probably going to get about 75% of your benefit from a medication about 8 weeks in. But that other 25% can come over the next 4 to 6 months. And again, the ripple effect of starting to feel better, I can't emphasize how important that is, that anything that you can do, anything that you can add into your life to help your mood is just going to keep the benefit coming. So yes, you have potential to see improvement.
All right. There's another question by one of our attendees who's asked, Celexa 10 mg caused my heart rate to increase, which frightened me. Would this be something that would subside after 1 to 2 weeks, or should I try something else?
It's certainly something that could potentially subside. What I might consider doing would be dropping the dose down to 5 milligrams. And usually what I tell people is, if you're on a certain dose of a medication and having a side effect, it should subside in 7 to 10 days. If it doesn't, it may not. So it all depends on how tolerable the medicine is. As long as your heart rate's in a safe range, I would certainly check with your physician, and it's not too uncomfortable for you, then it may be worth waiting it out. Having said that, if this is the first medicine you're taking and you'd like to try something else, that's another option. And if it's too scary to think of continuing on, I would definitely consider another option, and I would probably go with the lowest possible dose. Some of these medicines come in liquid form, and so you can really get a very, very low dose to start with.
Okay, there's another person who's asked about Celexa. I think she wants to know about how to get off it, because she's asked Celexa be tapered, and she's also asked how long is it optimal to take it.
That both of those questions are really very, very individually based, and that would not be something that I could answer for you specifically, unfortunately. I think I addressed, how important it is to keep taking a medication until you're as safe from a relapse as possible. So if you're in remission from a medication and you've been in remission for 9 months, then the option of tapering is there. It depends on many factors whether it makes sense to taper, and it certainly depends on your own history. Some people who've had multiple depressive episodes have enough impairment that they really need to stay on medication indefinitely. So that's really an individualized decision. And tapering, again, you should talk to your doctor about whether you should taper, when you should think about tapering, and how to do it. For me, the slower the better.
All right. There's another attendee who's asked, what about the use of Lamictal for people who are depressed but do not have bipolar disorder?
I think because lithium lithium's used for bipolar disorder, and lithium certainly has an evidence base behind it that can be a good adjunct to the treatment of depression. I think it makes sense to try Lamictal as well. I don't know that there's that much literature on Lamictal for depression that's not in the context of bipolar disorder, but in general, it's a pretty well-tolerated medicine. And I think if you've tried several things, it may make sense to try Lamictal either on its own or in combination with something that's given partial response. So Lamictal is definitely an option, but wouldn't be one that I would consider first, second, or even third line necessarily.
We have another question about Celexa. Can Celexa cause anxiety and shakiness?
It absolutely can. All of the SSRIs and SNRIs, when they're first being taken and feeling a little agitated, most people describe it as feeling like they've had too much caffeine. It's usually a very physical sensation. That's a very common side effect. Usually the way to mitigate that is to start on the lowest dose possible. And sometimes people will take an anti-anxiety medicine on an as-needed basis to help them get through that first period of time. But taking Celexa ongoing with that kind of side effect wouldn't make sense necessarily. But again, I don't want to make specific recommendations for someone I've not evaluated, but it's certainly something you should bring up with your doctor.
Okay, another attendee has asked, what about Topamax as an add-on?
You know, Topamax just doesn't have a great track record as being a good antidepressant or a good mood stabilizer. It's used for other reasons. It's felt to be helpful for weight loss for some people. So sometimes it's used as an add-on to counteract weight gain. I don't know how effective that's been. I tend to steer away from it just because it has a lot of side effects. It can be sedating, and it can make people feel very dulled cognitively. They just feel like they're not as sharp mentally on it. So I try to steer clear of that. That wouldn't be something that would be high on my list. For people who are bipolar, Topamax was thought to be something that would be a good add-on, but it's really not proven itself.
Okay, then we have another question here. An attendee has asked, is it helpful for women who report an increase in depressive symptoms during their period to increase the dose for 1 week?
Yeah, you know, there are a lot of people who will do that. And if you really know your cycle well and you know when your symptoms are going to come on, sometimes, you know, increasing your dose 2 or 3 days before the onset of symptoms can be effective. In my opinion, it is hard for most people to be that on track with their menstrual cycle, and it's often hard for them to keep such close track that they can make that increase before they know it. They'll find that their symptoms have worsened already. So in some cases, it might make sense to just increase the dose, you know, all month long. But yes, that is definitely a strategy that can be effective if it's doable.
Okay, then, another attendee has asked if grief can turn into a major depressive episode if after a year a person is still not doing well.
It absolutely can, and a year is a long time to be grieving to the degree that there is some kind of functional impairment in your life. You know, obviously grief can go on for many, many years, but it usually lessens over time. So my rule of thumb is if grief has not started to significantly improve, if the symptoms of grief haven't started to significantly improve after several weeks, and there's a high degree of functional impairment, then some intervention probably needs to happen. I would probably recommend psychotherapy first, but again, depending on the severity of symptoms and other issues, like we talked about initially, medication might be warranted in that case.
Right. One attendee has asked, will physical symptoms fade as the depression lifts?
They should. They absolutely should. Plenty of times people only get a partial response and all of their physical symptoms don't fade. But yes, the physical symptoms and the emotional symptoms of depression are equally responsive to medication overall. In each individual, you know, you're going to see, you know, that certain symptoms will respond early, certain symptoms respond later, and some don't respond. But the physical symptoms should respond in general.
Okay, and one attendee has asked, several of my anxiety patients with SSRIs complain of bad headaches. Is this a side effect that tends to go away?
It absolutely can be early on in treatment, especially. Again, you know, if the headaches are tolerable or if they are responsive to over-the-counter medicines and the patient can take those medicines and the headaches are not, you know, enough to make the patient not be able to function, then usually if they can wait a couple of weeks, they should improve.
All right. I think we are coming to the end of the hour, so we have to stop. Thank you, Dr. Salcedo, for this very informative webinar. Thank you all for attending this webinar. There are a couple of questions we couldn't get to. We apologize for that. We hope this was helpful. Please let others know about this series and consider making a contribution to ADAA. Thank you very much, and good night, everybody.
Thank you, Suma.
Bye-bye.
conference is no longer being recorded. You will now be disconnected by the moderator.